When I found out that I needed another fusion, it's a little bit like a body blow. It takes a while to absorb it and to get used to the idea of it and to start dealing with it in a way that you can.
So a fusion surgery is indicated for multiple reasons, but the primary idea is that the disc and the facet joints are so degenerated that they're causing pain, especially if there's instability, where the bones are shifting in relation to each other. A fusion can be extremely effective at stopping the motion, taking the pressure off the nerves, and stopping the person's pain.
It scared the hell out of me. I walked out of the office basically in a state of shock, and came home and sat my girlfriend down and said, I think I bit off more than I can chew. And by the way, I have done anesthetic for these operations, so I really knew what it entailed.
In order to get a fusion to occur, there's three things that you need. You need a big surface area. So we're gonna usually take the disc out, put bone or a spacer into the disc space in order to get bone to grow across the disc space. The second thing you need is you need compression. You need loading to get bone to grow. And 80% of the weight goes through the disc. So if you put a bone and a spacer into the disc space, that's where all the loading is occurring and that's where bone will grow.
The surgeon that I picked does 3-4 of these a week. And I just said, I'm gonna go through this. So for the next 2 weeks, I was in a good place and just accepted it.
The third thing you need for a fusion is you need stability. You have to stop the motion. It's like putting a cast on the arm to stop the motion to let the bone grow in a fracture. So these screws are called pedicle screws, and they go all the way across the vertebra. They're about 4 to 5 centimeters long, and then they're connected by rods in the back, and that stops the motion across the disc and across the facet joints to allow bone to grow.
Unfortunately, about 9 months ago, I was in a Pilates class and ended up doing one more move, and at that point, I felt muscle spasms that I hadn't felt in 20 years. So unfortunately, I knew the feeling, and I was afraid of what it might mean.
So there's different ways we get to the disc. We either go from the front, the side, or the back. Going in from the front, an anterior approach, sounds kind of crazy at first to patients. We don't actually go through your stomach. All your organs are contained in a sac called the peritoneum. We go around the left side typically. The biggest risk of going in the front is typically that your blood vessels sit on the front of your spine. Your aorta and your inferior vena cava, the two biggest vessels in your body, go down and split to go into your legs. So we have a surgeon who typically works with us, a vascular surgeon, who moves those out of the way to get us access to get to the disc. From a spine surgeon's perspective, going in the front is generally one of the easiest, best, safest surgeries we have. Because once everything is moved out of the way and retractors are put in, this is our view of the disc. So it's just bone and bone. Then we put a bony spacer in or a plastic spacer with bone in it so that then bone will grow across the disc space. If there's still disc or soft tissue, it blocks the fusion. The spacers we put in from the front are big and they're generally wedge shaped, and so that opens up the front of the spine. When people get degeneration, the disc typically collapses down. Older people get more and more bent forward, in part because the discs degenerate and they all collapse down and they lose muscle strength. We don't want to fuse them bent forward like this, because if we fuse this and stop the motion, these other levels have to hypercompensate to get them to stand up straight. And so that can put more stress on the other discs and may increase the chance of those degenerating. We like to go from the front or the side to jack open the disc to get the height back, so that when we fuse it, it may put less stress on these other levels because they're in a better position. Sometimes we can put screws into the spacer from the front to provide the stability, and then that's it. A lot of times we'll go from the front to take the disc out, put the spacer in, and then go in the back and put in the pedicle screws in the back and lock it down in the back, because from the front and the back at the primary surgery is the most stable construct we have. And the chance of it fusing and getting successful bone growth is excellent.
I went in for an MRI just to confirm what I thought, and unfortunately the disc above the L4, L5, the L3, L4 disc had herniated, which they say is common for people that have issues with one disc, is that the disc above it no longer has the foundation. There's more stress on that particular one. So the doctor wasn't too surprised.
Another way we do fusions is, instead of going in the front where we have to move the vessels and everything out of the way, we can go in from the side. And the side isn't called an X-lift or a D-lift, we call it a lateral. The benefit of going in the side is we don't have to mobilize your blood vessels out of the way. So it's a safer surgery and a faster recovery because we just don't have to move everything out of the way. A lot of times your pelvis will block access to L5-S1 and sometimes L4-5, so we can't get to it from the side. The third way we do fusions is all from the back, where we'll take out a facet joint and take the disc out from the back and put the spacer in from the back. That's called a T-lift. The success rate has been shown to be just as good as the other approaches, but the access to the disc is not as good from the back because the nerves are in the way. So we work through a smaller hole and the spacers are not as big. So it's a good surgery in certain situations, but in our practice, we like to go from the front or the side typically more often because we can put in bigger spacers and get better correction of deformities.